In this next section, we're going to introduce the challenging concept of oxygen and hemoglobin and the association between the two. Next section on diffusion, we're going to talk about how oxygen crosses out of the alveoli into the bloodstream and is carried by hemoglobin. If you're going to use Red Bull or espresso, now's the time to do it, because this is some of the more challenging stuff in pulmonary physiology. You've probably seen the oxygen dissociation curves before. This is often tested on in physiology examples. I both like these and don't like these. It's a little bit artificial, but I think it's worth spending some time going through. What this graph is showing is for any given PaO2, or arterial oxygen tension, how much hemoglobin will be saturated, or how much hemoglobin will be bound to oxygen. So for example, from this slide, if we look at an arterial oxygen of 100, we would expect 100% of the hemoglobin to be oxyhemoglobin or bound to oxygen. The important thing about this curve is that it's nonlinear. This allows an area at the top of the curve where a relatively large change in PaO2 doesn't produce much change in the oxygen saturation, the SaO2. It also allows for the steep part of the curve in which a small change in the PaO2 is associated with a big change in the oxygen saturation. The flat portion of the curve at the top of this curve is more in line with what's going on in the lung. There's a big drop-off of oxygen onto hemoglobin. As we get down to the more steep part of the curve, it represents what's going on in the peripheral tissues. There, we want oxygen to come off of hemoglobin to diffuse out of the capillaries into the tissues that need oxygen. There's a lot of talk about what can shift this oxygen-hemoglobin dissociation curve to the left or to the right. Let's talk about some of those factors. Things that would shift this curve to the left would promote more oxygen being bound to hemoglobin for any given PaO2. Things that are going to shift this curve to the left include a low PCO2, low 2,3-DPG concentration, lower temperature, or lower amount of hydrogen ions, or a higher pH. This left shift is favored in the pulmonary circulation. It favors oxygen being bound to hemoglobin and optimizing the oxygen carrying capacity of the blood. Let's compare this with a right shift of the oxygen-hemoglobin dissociation curve. Things that may cause a right shift of the oxygen-hemoglobin dissociation curve would be a higher PaCO2, a higher 2,3-DPG concentration, or higher temperature. Also, higher hydrogen ion concentrations, or a lower pH. For this right shift, we're favoring oxygen being dropped off in the distal systemic capillaries. Oxygen is less tightly bound to hemoglobin, and it's going to promote more of it being left in the tissues for use by them. Let's bring up a couple of key points along this curve. Sometimes we refer to the shoulder of the curve, the point, for example, in between B and C. The shoulder of the curve represents where it changes from being relatively flat, where a large change in PO2 produces a relatively small change in oxygen saturation, compared with the steep portion of the curve in which a small change in PaO2 produces a big change in O2 saturation. That shoulder is an important point because it's the point at which, if the patient's PO2 is below that, we're going to need to supplement their oxygen. That corresponds to a PaO2 of about 60 or an oxygen saturation of 89%. we know that if a patient has a PaO2 of 60 or a pulse ox of 89%, beneath that, they're going to start losing the amount of oxygen that's being carried, and we would need to supplement them. For example, Medicare will only pay for supplemental oxygen if someone's O2 sat is lower than 89%. Medicare knows what the oxygen-hemoglobin dissociation curve looks like. Remember, this is an idealized curve. We never really know exactly what happens. And I don't sit around in the ICU talking about, does this patient have a left-shifted or a right-shifted oxygen-hemoglobin dissociation curve? To some extent, it's going to be dependent on which part of the body you're looking at. For example, if I stood up here and we're doing bicep curls, as my biceps began to exercise, they would raise the temperature, they'd raise the CO2 production, they might even become anaerobic and lower the pH. That would create circumstances by which I right shift the oxygen hemoglobin curve just in my biceps. It's going to favor oxygen being dropped off in my biceps compared to my legs that maybe weren't exercising. In review, the amount of oxygen that we can carry is dependent on the amount of hemoglobin we have and the percent of hemoglobin that's oxyhemoglobin and not deoxyhemoglobin. Left shift of the oxygen hemoglobin dissociation curve favors oxygen uptake in the lungs, whereas a right shift would favor oxygen drop off in the peripheral tissues. In a clinical setting, we often measure the arterial blood gas. We might get a pH, the arterial CO2, and the arterial O2 from this gas. Sometimes venous blood gases are measured as well. These can be used to calculate the AA gradient and can be used to give some information about the acid-base status of the patient. Arterial PCO2, or P-little-a-CO2, directly reflects alveolar ventilation. Remember, carbon dioxide diffuses very well from the capillary into the alveoli, so that whatever the arterial CO2 is going to equal the alveolar CO2. The arterial CO2 is a direct balance between the amount of CO2 that's produced and the amount of CO2 that's removed in the lungs. So an elevation in the PCO2 suggests either increased CO2 production, as in the case of fever or exercise, or inadequate CO2 removal, as in the case of alveolar hypoventilation. CO2 diffuses very quickly across the alveolar membrane. It's stored in the blood in three main forms. Some of it's dissolved, some of it's bound to protein, hemoglobin, and other molecules, but much of it is buffered in the bicarbonate system. The amount of CO2 in the tissue outpaces the lung's ventilatory capacity, so we store much of the CO2 as bicarb. The conversion of CO2 gas to bicarb that you might find in the blood is catalyzed by the enzyme carbonic anhydrase. This is also the reason why patients that chronically have a high CO2, chronically alveolar hypoventilate, sometimes will have a high bicarbonate on measurements of their blood chemistries. Let's do a question. A patient in Dallas is put on 40% oxygen. His ABG shows a PO2 of 70 and a PCO2 of 40. What's his inspired partial pressure of oxygen? So remember, let's do this for the inspired partial pressure, not the alveolar partial pressure. And we know that he's in Dallas, so we're at 760 millimeters of mercury, minus 47 for water vapor. But remember, he's not breathing room air, he's breathing 40% oxygen. So it's 760 minus 47 times 0.4, which equals 285. C is the correct answer. Remember, this is his inspired oxygen, not his alveolar oxygen. To calculate his alveolar oxygen, we would need to take into account the PCO2. A 24-year-old woman is running a marathon. During the race, her CO2 production increases by 100%, her heart rate goes up by 300%. What needs to happen to her alveolar ventilation to keep her arterial CO2 the same? So if her CO2 production increases by 100%, we know we need to increase the alveolar ventilation by 100% as well to keep the PaCO2 the same. The heart rate information there is just thrown in to distract you. The amazing thing about this is exactly how our body works. If you measured blood gases on people finishing a marathon, in general they'd have a normal PaCO2. So when we exercise, we increase our CO2 production, but our body knows exactly how much to increase our ventilation to account for that increase in CO2 production. It's remarkable that it works as well as it does in health. Considerable problems can occur, however, in disease. That concludes our discussion of oxygen and diffusion.